Hello and welcome to Level 5 Health and Social Care, Unit 502, the Quality Unit. And this is week 2. We're looking at this week, we're going to look at CQC, the Care Quality Commission, and we're going to do a little bit on benchmarking as well. Okay. So the two criteria we're looking at, this is task 2 this week. And it's looking at two criteria. 2.1, which is critically analyse the role of the Care Quality Commission in maintaining quality in health and social care. And 2.2, analyse the role of benchmarks in maintaining quality in health and social care. Just as a heads up, 2.1 wants you to critically analyse. So you really want to look at strengths and weaknesses here, and you want to pick up some critiques of the CQC. Whereas 2.2 isn't so critical, but it wants some analysis in the role of benchmarks. So a little bit of balance, but maybe not so much as a heavy critique as in 2.1. Okay, so when you're using your 600 words, just think about that. Okay, let's start by looking at CQC. We've talked about them quite a bit in your level 3 and your level 4, but I'll sort of refresh your memory. CQC is the Care Quality Commission. It's a non-departmental public body. It's part of the Department of Health and Social Care of the United Kingdom. It was established in 2009, but really the CQC sort of inspection had been going for many years before that, but that was broken up under 3 organisations. Mental Health Act Commission worked on their own, basically looking at people who were detained under the Mental Health Act. That became part of CQC's job. The Commission for Social Care Inspection had a real focus in care homes and stuff out in the community that was social care organised, that wasn't necessarily nursing led or doctor led in that sense. And the Healthcare Commission focused on hospitals and doctor surgeries. And what happened was they just merged the 3 of them, really. So the stated role is to make sure hospitals, care homes, dental and general practices and other care services in England, and it's particularly England because the other countries have a slightly different format. So we're just focusing on England here. Okay, so make sure you're clear about that. And it's to provide people with safe, effective and high quality care, also to encourage these providers to improve where they need to. And its main way of doing this is the registration process and then the sort of visits and checks that they do, generally annually, sometimes more frequently, sometimes less. Okay. And they provide reports which go onto a website and people can look at them. So what do? They make sure that health and social care services are safe, effective, compassionate and high quality, and they encourage them to improve. They register health and adult care services that meet the fundamental standards. So there's a set of standards they work with based around quality and safety. And if a service meet those, then they will register them and they will be part of it, and then they will be available for inspection visits in the future. So before a care provider can actually operate in this country, they must register with CQC and they must satisfy CQC that they can meet the fundamental standards and all the legal requirements, so they have to meet all the legislation standards as well, like data protection, safeguarding, all those sorts of things that we know. The activities that they regulate is quite wide ranging now because, as I said, the 3 bodies have come together. And there is only one body that does everything. So they regulate treatment, care and support provided by hospitals, GP practices, dental practices, ambulance services, care homes, and home care agency, and clinics as well, which they sort of tend to look at as hospital services. But they, in this country, they cover private clinics as well. So if you're a private health clinic or I don't know, a cosmetic surgery clinic, they are actually covered by CQC and they are inspected as well. The CQC standards are it's an unfortunate word that it creates, but they are safe, caring, responsive, effective, well led. That's what they're looking for when they register people. So to be safe, are people protected from abuse and avoidable harm? Have you got all the relevant processes in place to demonstrate that? Caring, when they inspect, do they see staff involve and treat people with compassion, kindness, dignity, and respect? They're the areas that they're really looking for, interactions, the way they help people, maneuver around. Are they responsive? Are they organized to meet people's needs, or do they not meet people's needs? Are they effective? Is people's care, treatment, and support, do they get good outcomes? Is there a good quality of life being promoted? And is it based on the best available evidence? And is it well led? So they also look at the leadership and management and the governance and the policies and procedures that the organisation's got in place. And does all that leadership make sure that the delivery of person-centered care is of a high quality? Does it support learning and innovation? Does it promote an open and fair culture? It's possibly an area where they can be in their weakest, I just want to say. They do make comments on leadership and management, but that is where they have fallen down, even though they sort of they don't really push enough improvement in that area. On the learning and innovation and the open and fair culture, that's been known to be a weakness. So CQC and the Mental Health Act, they do have a responsibility under the Mental Health Act, and as for monitoring and reporting on how the Mental Health Act is used, and that it's used appropriately on service users. And they also have a sort of slightly secondary issue. They actually visit people whose rights are restricted by the Mental Health Act, and they have to act on any matters of concern for the service user. They provide a service to safeguard, protect patients who refuse their treatment. They have to support them because sometimes doctors are not happy about that. Or more importantly, they have to safeguard people who aren't able to give consent, and they have to be involved if people want to do interventions against the person's will. They would be involved in that. They regularly, whenever they do an inspection, they publish a report with 4 ratings. Some might say, well, lots of people feel the ratings are a bit unfair, because there are only 4 of them. Outstanding, good, requires improvement, inadequate. There's not much room for things that sort of flip between the two. And one of the criticisms is how they come to these 4 statements, because they put this at the head of their report, and when people are checking up on care homes, they might just go outstanding, good, but if it's got requires improvement, sometimes people don't drill down, and you could find that it's actually quite a simple thing, like it's in the process of having a new wing rebuilt, which is causing issues for people, but it's only temporary, and so some people are saying that the one word paragraph is not really saying enough. It's not encouraging people to drill down. Some people are lazy and don't read the reports completely. Lazy is my opinion. And they don't really find out enough about it. And how they decide, there's quite a few different areas they look at, and you could actually be performing quite well in certain areas but go down in one. You could have had a safeguarding incident which will knock you down from good to requires improvement, even if quite a lot of your other reviews are good. That makes sense. So there's a lot of criticism about the reports, and I would suggest you sort of like read into that. There's lots of Google stuff about criticism of the way they do their reports. So that's just a little heads up for you. So what can CQC do if they have concerns? Well, it depends on how serious the problems are. They can do the following. They can give you, and this is what they generally do, they give a care provider notice setting out what improvements they must make and when. They usually have to give them a date. And sometimes they can have a bit of a discussion over that date, and a good inspector will listen to what the care provider has got to say. They can hold a care provider to account by issuing a simple caution, which is a little bit more than just a bit of improvement. It's like a warning, basically, if you don't do this by the way, we will go ahead and fine. They can issue fines, although it's questionable how they decide how much and that. They can prosecute. Certainly, if the law's been breached, that can actually go out of their hands and the police can prosecute anyway, especially safeguarding. Where people are harmed or placed in danger, they can prosecute on behalf of the health and safety executive as well if you've done something really dangerous and it's a breach of health and safety law, because if they don't, the health and safety executive will step in and do it. But they can do it on behalf of health and safety. They can limit what the care provider may do for a set time. So they may say, while you're doing this development in your care home, we're going to limit the amount of people you can have in it from, say, 30 to 20, because we think that there's not enough space for the other people. So they can say you can't do that, or they can say you can't take any new admissions while you're sorting out your staffing problems, so they can say, they can put a limit on things. At the very worst, they can place a care provider into special measures, which will give them a clear timetable. And usually when they go into special measures, they're not allowed to take any new people. And if the special measures fails, there's a good chance the registration will be cancelled. If the registration is cancelled, then the care home is not allowed to operate and basically they close down. That's pretty much it about CQC. That's their role. But what I have done is I've got some resources which have some critiques, where maybe things don't go that well. I've done a couple for you. And I'd like you to have a look at those to help you critically analyse the role. So, you know what the role is. It's quite simple. And we've talked about CQC in our level 3s and level 4s as well. So you're fully aware of it. And do, in your private study time, please read the resources I've put there, which I think there's a couple of documents for you to help you critically analyse the role. Okay. You can also do a bit more Google research. And if you do pick up something, please don't forget to cite and reference it. Okay, you will find stuff. There's a lot of stuff in the newspapers every now and then about where people think they might have got it wrong or where they don't do it very well. So you're not going to be short of stuff to find, I can assure you. So have a look. Again, if you're not sure, the WhatsApp. Okay, we're going to move on to benchmarking. And I've put it's big in the NHS because it really is. I don't know if it's big in the medical services of your home countries, but our NHS has sort of grabbed benchmarking and run with it very happily. So where did it come from? It's another one that comes from industry, like some of the quality improvement models we looked at before. and the benchmarking came out of said quality improvement models. And it's been quite a structured approach to quality measurement, improving services. And they've been using it in the NHS. Well, it's been in business since the 70s. And this process was competitive, really. And the idea is, for like-minded businesses to compete with each other and to meet or surpass the best performer. So it's very competitive. Now, this was introduced in the NHS when they launched the Benchmarking Club, which was sponsored by the NHS Management Executive in January 1991. And the club focused on benchmarking organisational issues rather than clinical ones. So it was more about the way the hospitals ran and how they were organised, rather than how many cancer patients were treated and things like that. Although it did move into that in time. And it focused on things like cancelled operations, non-attendance, and it still looks at stuff like that today. And it frequently gets quoted in newspapers when it's not too good, and by the government when it is good, as you can imagine. So the benchmarking is not going away, but it was also introduced a point when a previous government was trying to encourage a bit of competition between the NHS, probably with a long-term eye on things going private, so that they were actually creating competition between different departments of the NHS. There's a lot of view about that now, that was a bit of a stupid idea. However, I don't think the Tory government has really given up on it completely. So, definition of benchmarking: the practice of being humble enough to admit that someone else is better at something and being wise enough to try to learn how to match and even surpass them. Sounds quite good, doesn't it? Yes. Department of Health view is clinical benchmarking. As you can see, it moved into clinical. Systematic process in which current practice and care are being compared to and amended to attain the best practice. So someone's obviously got to be identified as the best practitioner, and then other people, the idea is that you've got to try and meet them or beat them. So it's built on performance comparison, identifying gaps where people aren't meeting best practice at all, and then changes in the management process. It's usually about the way the management process works. It's not about whether one consultant is clinically cleverer than another. It doesn't really look at things like that. It looks at sort of achievement, how many people are satisfied with their cancer treatment, how many appointments have been missed, how many people have turned up for their appointments, how quick, how many operations are missed. That's one that we hear most weeks. If you ever watch the government online, and there's always about that when it, as I said, it's usually the opposition party is sort of pointing out where lots of operations have been cancelled. It's a favourite of theirs. So it identifies strengths and weaknesses within the organisation, identifies the level of performance possible by comparing to the performance of others, and sort of, drawing attention to the ones who achieve the highest, so that people know how much improvement there is that they could achieve. The idea is to promote change and deliver improvements in quality, productivity and efficiency. So not just quality on its own, but productivity and efficiency. You might want to discuss if one gets sacrificed for the other. I'll leave that to you to do a bit of research on. And to help better satisfy the customer's needs. So they do customer satisfaction as well. Why do it? Over the last few years, there's been examples of poor care in the statutory and non-statutory sector. There's been some events at Stafford Hospital which exposed the Francis inquiries where people died when they shouldn't have, through bad organisational processes. You can find the Francis inquiry reports 2010 if you Google them, very easily. It demonstrates what happens when things goes wrong, when the interests of patients are not put first, and when their concerns are not listened to. As nursing staff or care staff, we need to ensure that we are taking every possible step to ensure that patients receive consistently higher standards of care. Benchmarking helps because you can evidence your performance against the best in the country if you want to. It's a vital tool and it's recommended in reports. The Berwick report was a response report to the Francis inquiries. Okay, I've added the Berwick report to your resources for you to have a little read. And clinical benchmarking is recommended as a tool to use, really. A lot of people take this pretty seriously. Some people find it frustrating, but a lot of people take it pretty seriously. Getting it right really relies on knowing about the best practice, and that can be difficult to find out because the NHS is huge, and finding out about best practice, you've got to read all the right journals. We've got to think about whether the staff have time to do that, and you have to think about how well they get informed of best practice. Where does it come from? Okay, so benchmarking can really be a good tool. It's particularly good for those in very specialised units because they can't often compare themselves with the people next door. So they might want to find a specialised unit in another part of the country that's doing very well that they can compare themselves to. And it can be quite difficult. Well, as I said, if you want to look further than just in your own organisation. So you will get some wards that benchmark against each other within an organisation. But to be really effective, you want to go out and find the sort of best practice leader. What are the advantages? It's systematic, which is good. It's sort of organised. It's scientific, so it's you can evidence it well. It does promote reflection in practice because you're benchmarking and comparing to someone else. You will naturally reflect on your own practice and think, gosh, do I do it like that? Do I do it? It provides an avenue for change because you've got the evidence to work with. And it's a way, if someone is doing something really creative and innovative, because they hopefully will get picked up as best practice leaders, it's ensuring that doesn't sort of disappear somewhere. It tries to stop you just repeating effort for no purpose by actually, say, right, I might not need to do that anymore because that's not achieving anything. The idea is to reduce fragmentation across the NHS. If you're benchmarking with someone in, the other end of the country, hopefully in time those geographical variations will be a lot closer together. It provides evidence, and as I said, the government likes to quote it very often, and so do the opposition parties when it fails as well. But, an NHS, if you have a look at any hospital's annual report, they will have their benchmarking stuff in there, sort of giving you evidence, you, the reader, evidence. It facilitates multidisciplinary team building and networking because teams work together on the benchmarking process, gathering the information, producing it, and then deciding what to do with it afterwards. And then there's a team building feel when you get together to think about what you're going to do. And if you see there's gaps, you've got to meet. So it provides a forum for open and shared learning as well. It's generally practitioner-led because it's the people within the team that tend to do it. So it gives them sense of ownership as well when they've sat down and talked about, okay, this is where we are, this is where the good guys are. Okay, what are we going to do? So it does accelerate quality improvement because you've got something to work with. So because they're doing it regularly, the benchmarking, you're not having to go out and do something specific for a quality improvement. It improves the transition of patients across complex organisational care pathways. Um, when people are moving around, you know what they're moving to, and you know the standards, and and it contributes to an MC revalidation process. So for those who are people who are nurses under the Nursing Midwifery Council, they have to revalidate every year. So they have to show that they've done reflection, done some CPD, and if they take part in a benchmarking exercise, that counts as reflection and CPD, so that they've met some of their own standards. Where's the best practice? Where do you get it from? Available research, and the university hospitals and the universities are doing research all the time. And you'll find out through literature searches, sharing articles, references, just as you do when you're finding something for your assignments. Practice examples that people know about and have read about, and often articles that are in your professional journals, such as the Nursing Times, the BMJ magazine, the Lancet, just to be examples. Community care for people who are care workers is a great one. And good practice, their job is to find good practice examples and do interesting articles about them. And people can bring those to meetings and share and compare. And professional consensus, which you do when you actually do your practitioners meeting. So again, the idea is to publish things, and it will come in annual reports and that. So the benchmarking wheel, yes, it's another wheel. Yes, most things are. And it isn't that different from your quality development ones. It might have a few more steps, but really it's the same. So you start off at the beginning, at the top of your wheel, to identify the area of practice you're benchmarking. Okay. Number 2 is the expert input. So get feedback from your practitioners, your clinicians. Number 3 is the patient-focused outcome. So what would your service users like to happen? So what sort of improvements are they looking for? Then you identify how you're going to measure it. So let's say the example is waiting times for, we were talking about in week 1, an example of a cancer treatment service. So a patient-focused outcome would be, having to wait too long for their first possible cancer diagnosis. So number 4, identify measurement factors. So the measurement factors you'd be identifying there is the waiting time. How many days is it? Number 5, identify the benchmark and best practice. So this is when you might do a lot of literature reviews, a bit of research, find out who's practicing best. So, maybe the best practice is no longer than 3-day wait. And maybe your wait is 15 days. Okay. Number 6 is construct a scoring method. And with benchmarking, they have all sorts of complex scoring methods. Some more sensible than others, really, but some too detailed. But you construct your scoring method. Number 7, you look at your own practice over a period of time, score it, compare it with the best practice score. Number 8, share the examples with each other or whoever's on the team. And then you do an action plan for change so that you can better meet that best practice score. So scoring the benchmarks nowadays is mandatory in all clinical areas, and you have to construct a scoring method from each factor, and it's usually from poor to best. Some of the original ones were just on a numeric scale, 1 to 10, 10 out of 10 being good, 1 out of 10 being rubbish. And then they did an A to E scale. I've worked with benchmarks that go from red, green, and gold. And that's where you've got a lot of standards. So rather than scoring each one individually, you might have an overall number. So red indicates about half the standards have been achieved. Gold indicates that all have been achieved. Green's about 75% of them. Yeah. Other benchmarks will just use a statement of best practice. That becomes a bit harder to score, but you've got to try and find a statement that can be measured. It's a bit like some of your action planning and your quality improvement. You need a statement that can be measured. So again, it can't be too floaty or airy-fairy, really. It's generally, people find it easier to use an actual scoring number than just a statement because it's quite hard to justify just a statement. It's worth taking time over that. If anything, take time over the scoring as part of the planning process. Needs to be fairly rigorous. As I said, using a SMART. If you use a statement, it needs to be SMART. Specific, measurable, achievable, reliable, and time-led. So what are the pitfalls of benchmarking? Sounds good, sounds useful, sounds sensible if you're measuring yourself against someone better. Can be a really useful tool. However, there are some things to avoid. Okay, so if you are critically evaluating it, you might want to think about it. Lack of context. In most cases, benchmark data is stripped of short and long-term context. It means it just tells you what someone's achieved, but it doesn't tell you what they had to do to get there, which can be difficult for your areas of improvement because you might be halfway along that journey somewhere. And yes, you haven't achieved it yet, but what are you doing the fact that you are achieving it or you may achieve it in a couple of weeks? The measurement issues, well, this is difficult because not everyone measures in the same way. So you need to know what, if you're comparing it against the guys in another town who got awarded best practice, how did they measure it? Because you may never meet them if you didn't measure it in the same way. So think about that. The only way that you can really meet their achievement is doing a like for like measure. But that can be quite difficult unless you're able to go and visit this team. And to be honest, if they're the best practice team, they can't be visited by every other team in the country doing the same job. It's really difficult. And you can also, measurements can get thrown out by one-offs. Like all the power went down for a couple of days or something, so you couldn't have any appointments. Measurements don't really pick that up. Obviously, if you're writing your report, you can justify it with that, but your measurement will still never be quite right. Finding comparisons might be difficult. It depends on the industry. It depends on the team. If you're really competitive, they might not want to share with you, especially if you're doing it in a care home where you want to compare to other care providers. In the NHS, they all work for each other. So in that sense, an NHS, say in London, wouldn't be any difference from an NHS in Manchester because it's all run by our government in that sense. But with care home providers, you're all individual organisations making your own profits and paying your own bills. So they might not want to share data because it's competition, which might be difficult. So you might have to end up comparing it with, an NHS care home, which is probably not going to be the same with different funding and that. So it's hard. Finding reliable can be difficult. People use aggregator sites like, if I was a hotel, I would probably use TripAdvisor and look at the reviews. If I was a restaurant, I use TripAdvisor, but we don't really use TripAdvisor for care homes. Um, and there's a lot of people who say that, you know, those of you who know about TripAdvisor, you know, that it's biased and people just write anything or they get their friends to write things. So we don't really know how good the data is, do we? So if you were care homes, the only thing you could probably use in this country would be CQC inspections, you know, their inspection report against your inspection report, maybe. And the other thing about benchmarking is it looks backward. It can only tell you about what has happened. It can't tell you about what you're going to do, and it can't tell you about what the changes you're making at the moment, how how that's going to change things for you. So past performance is not a guarantee of any future performance. Benchmarking is like a snapshot. That's how it was in February 2023. But here we are, you know, that doesn't promise that you are still going to perform the same in February 2024. So it's always retrospective. Okay, that's all there really is on benchmarking. I've given you additional 2 benchmarking resources for you to have a look at. One, how benchmarking contributes to quality improvement. And the other one is, which I think is quite interesting, it's on the NHS 70 years of the NHS. And there's issues there's discussion around benchmarking in it, which hopefully will help you analyse the role of benchmarking a little bit more. You don't have to be that critical, but there may be critiques that you pick up out of those 2 resources. But, you know, for this week, please do have a look at the resources I've given you because they will help with your analysis. Okay, so I've just given you a bit of an overview here, and really use those resources and any others that you find as well. And remember, you can find your own additional resources and quote them, but please don't forget your citations and your references. Any questions about this? I think benchmarking is fairly straightforward, really. Any questions about it? Don't forget to use the WhatsApp. Use a group WhatsApp if you can, because you know somebody else might have a similar question to you, and instead of me having to answer each one of you, which I do sometimes, it's nice if you get some shared answers. Someone's thinking, "Oh, I was going to ask that. Oh, that's helpful," you know. So there's no question is wrong or silly, so don't worry about that and just think about sharing it. Okay, so thank you for that. That's the end of week 2, unit 502. I'll see you in week 3.